Good afternoon, everyone. Welcome back to College of Physicians Weekly Webinar. Today's topic is heart selection and common interactions. We are very honored to have invited Dr. Wong Ping Xian from Hospital Pulau Pinang as our chairperson, and also Dr. Cheng Ju Tai as our speaker. Without further ado, let us welcome our chairperson, Dr. Wong. Over to you, Dr.
Thank you, Dr. Chan. Good afternoon, everyone. As Chan has mentioned, I'm Dr. Wong from Penang Hospital. I would like to thank the College of Physicians for inviting me to chair today's CME, which is the second lecture in the infectious diseases webinar for this month. Today's speaker is Dr. Cheng Ju Tai. Dr. Cheng graduated from University of the West Indies in Trinidad and Tobago. He did his housemanship in Hospital Taiping, and he has served in various hospitals as a medical officer and also specialist, namely Baling, Hospital Seberang Jaya, and Penang Hospital, and also Hospital Sungai Buloh. He completed his infectious diseases fellowship training in Royal Melbourne Hospital in 2012. Upon coming back to Malaysia, he was posted to Hospital Ipoh as a consultant ID physician. He is currently the head of ID unit in Hospital Seberang Jaya since March 2020. Dr. Cheng is very active in doing research and has participated in many HIV clinical trials and also COVID trials recently. His lecture today is heart selection and common interactions. Without further ado, I would like to invite Dr. Cheng to deliver his lecture. Over to you, Dr. Cheng.
Thank you, Dr. Wong. Good afternoon, everybody. Thank you, College of Physicians, for allowing me to share my presentation today. Share screen. And here, right? Can see also, right? Okay. So, my topic today would be antiretroviral therapy. Actually, the topic given was HAART, and just for information, I think most of the guidelines no longer use HAART, but more of antiretroviral therapy nowadays. Yeah, so that's why I changed the topic to ART, right? There was I still remember long time ago when we were talking about heart. I used to ask patient, have you taken your heart medicine? And the patient was a bit of surprise looking at me, asking, I didn't have any heart problem. Why should I have a heart medicine, isn't it? So that was part of it. Anyway, so to just give you a brief introduction about HIV, I think all of you would have known that HIV is the virus that causing the disease or syndrome we call AIDS or AIDS. And when you talk about HIV, we would touch on CD4 count, which is a cell, one of the cell line that we looked at in our immune system to actually determine the immune response of the patient, and also look at the viral load of the HIV virus when the patient is before and after patient on treatment to determine whether the medication works or not. Okay, so generally, without any treatment, if you look at the natural progression of the disease, without any treatment, you will see the red line is the virus. You will see that after infection, there is a sudden surge in the virus, the viral load, and after a while, the virus do come down to a certain extent and plateau off for a while before it goes up again. And during the process, somehow at the initial stage, the CD4 would still at a high level but gradually reduce. This is because the virus use CD4 as a factory to multiply themselves. So in the process, CD4 dies off early. So as the CD4 drops and all, to certain levels, patient starts to deteriorate with symptoms and also opportunistic infection. So this is the natural progression of the disease. And based on the level of CD4, we sort of know estimate that which opportunistic infection the patient is prone to. I think you had a very good extensive lectures about the low white cells and all last week by Dr. Ang. Yeah, so that illustrated some of the features, I think. CD4 progression. So basically, the way I did the presentation was assuming that you have a new HIV patient that presented to you, and after the lecture you should be able to feel more comfortable. You should be able to feel more comfortable in starting the patient on treatment, and also monitoring the patient further. So the first thing when you have a patient comes to you with a HIV positive, I think first thing is try to see the patient on the same day on the spot, as much as possible if your facilities allows you to do that. A lot of time the patient can be very anxious. You know, some of the patient may be quite calm because they already would have gone through a lot of information on Google's, and they would have asked. Some of them they already anticipated, but a lot of them they can be very anxious. So your review of the patient on the spot when they come to you is actually very, very important. The second thing I always remind myself is after a few incidences is to confirm the HIV status. This is that means make sure that the test the patient brought along is actually a truly valid HIV status positive, because it's not easy to simply label a person as HIV. Just 2 days ago when we had our clinic, just yesterday we had our clinic. After 10 years of treatment of patients, actually questioned us, was she really a HIV positive, you know, after 10 years of treatment. So I think these things do happen, and I think some of you would have come across the same scenario. So the first thing is confirm the status. Okay, it's very, very important, right? Next thing is, after you confirm the status, how are you going to prepare the patient for subsequent treatment and follow-up? Okay, so your first visit actually sort of determine whether your patient come back to you or not. And I think linkage to care, which you always hear from WHO, linkage to care is very, very important. Okay, so you prepare the patient. The first thing is the patient has to accept their disease. Okay, they have to accept their disease, meaning that they have to, a lot of time they will still be in denial. They will ask you, why me, you know, why I get the disease, how do I get the disease? And a lot of time when you inquire about the risk factor, they will tell you, you know, I didn't have any exposure, you know. So in the first visit, I probably won't be too aggressive in terms of looking for direct risk of exposure, you know, because after all, the exposure would be like sexual activities, you know. Not many people will reveal their sexual life and all to us when first attempt when we see them, you know. So I think don't get frustrated if the patient tells you that they didn't have any risk factors and all in the first visits and all. Sometimes they may not be willing to tell you, but when you after your review, you send to the patient to see your counselor, the patient may reveal more information to your counselors. Okay, so don't get upset about it. You don't get a lot of information. Then after explaining about the HIV status and the test and also the disease, you know, then you explore the social history. I think it's important in terms of social history, being such as marriage, partners. If marriage, some of them they are already married, some of them they are about to get married, you know, then they'll be very anxious if they're about to get married. Then they will ask you 101 questions like, you know, premarital status check, you know, how should I go about it? Should I continue with my marriage? You know, then if they have partners and all, then what is the partner status? I think I would be interested to know. And then other family members, like who is supposed to know about the disease, and then any other family members that is actually supportive for the patient. You know, it's also important because in the future when they started treatment, I think family members support is actually very, very important. And then a circle of confidentiality, who should know the disease, you know, the patient will make a decision. Okay, unless it's a partner or a person directly involved at risk of getting the disease. Other than that, I think a circle of confidentiality will be decided by the patient. Then occupation as well, because in the future, when you want to put a patient on treatment, the timing of medicine and all do make a difference depending on the occupation of the patient. For instance, if your patient is working as a security guard and works night shift, and you give them medication that causes them a lot of dizziness, then essentially they go there to actually not work but sleep. Then eventually you'll affect their performance. And then subsequently, after you explore the social this thing, I would probably look into the clinical condition of the patient, whether patient is just because you do have different stages of patient comes to you. They can be purely asymptomatic incidental finding. They can be having a constitutional symptoms but no opportunistic infection, or they can eventually come to you with opportunistic infection. Then exploring comorbidities is also important, because I think things like diabetes, hypertension, some of the antiretroviral may affect the metabolic, can actually worsen their metabolic syndromes. Okay. Then of course, drug-drug interaction, we will talk about more details in the later lectures. Okay. Then you probably would have to sort of touch a bit on antiretroviral therapy and the choice of treatment, dosage, whether you want to give once a day or twice a day, depending on the condition, what time to take the medicine, but always remember patient-centered plan. You don't decide, we don't decide the plan for the, we give the plan, we give a suggestion for the patient, but patient decide what they want to do. For instance, if you schedule the patient to take the medicine at 9 o'clock, you ask the patient to take at 9 o'clock, but patient say, I only sleep at 11 o'clock, I want to take at 10 o'clock. Or patient, so then I think it ultimately will be patient. You have to respect patient's decision and take that, let him decide what time you want to take. Another example is we had cases whereby the patient was asked to take the medicine at 10 o'clock, but patient actually slept very early. The patient slept at 8 o'clock. So patient have to set alarm at 9 o'clock or 10 o'clock to wake up and eat the medicine and go back to sleep. And you and I know that if you set an alarm will ring, and then you will snooze it off, and then you after a few time you won't wake up, eventually. So you'll miss the tablets. So I think all these things, and then you also want to discuss with them about the benefit of the medicine and also the possible side effects that they will have to anticipate. Okay, and subsequent follow-up is also important. And let's say the patient decide to not follow up with you, you might also want to offer them where else they can actually follow up with. All right. So yeah, so after you talk to the patient and all, you probably will send some blood tests and all. CD4 count, like I mentioned earlier, is probably the most important, one of the most important tests you want to do. But not all facilities actually can send CD4 on the spot. Some facility have to send it like early, like in Seberang Jaya Hospital, we have to send it like early in the morning, about 7:30. Patient has to come and take bloods and all, and transport will come after that. So a certain hospital has its restriction in terms of sending CD4. But it's not a reason why not for us not to start treatment, because you don't have to, essentially you don't have to wait for the CD4 results to come back in order for you to start treatment. Okay, and these are some of the tests. Actually, I took it from WHO because I think that's the latest. I know that we had our consensus guideline in 2017, and I think updates are in progress. So because we are updating our guidelines, I know I thought I probably won't use any of information from there yet. So WHO has the latest update on July 2021. So I thought just extract some of the information from there. Right, routine tests like FBC, RP, full blood count, renal function, and then liver function, you probably would do that. Hepatitis B and C screening, and then assessment for renal function. I think it's important because I will let you know later. Then screening for TB is one of the important things that our ministry is emphasizing on, and I think it has to be done for every single patient that comes to us. HIV test, of course, we mentioned, and CD4 count. But again, to re-emphasize, do not wait for the CD4 count to decide on the treatment. If the patient is ready for starting treatment, go ahead. with the treatment, because CD4 count in certain facilities may take a while to come back. And then also WHO did mention about cryptococcal screening, which I think at the moment we are not routinely doing it in our setting, but then I think it's something to be considered, because of the it's not freely available in many facilities. So I think I won't make it a routine test yet, but then in the future we might have to look into it, right? There's always a question. So when you say starting antiretroviral therapy, there's always a question when to start the treatment. Long time ago when we started antiretroviral treatment, a lot of time we always thought that you have to give 2 weeks. Usually, generally, most of the people will tell you 2 weeks of pill training. We call it pill training. I still remember you have to write the vitamin B and vitamin C to actually mimic the amount or number of tablets that patient used to take is going to take in the future. And then for 2 weeks you let them do and adjust the timing, and 2 weeks later you see them, and then if they are ready, then we start the treatment. Okay, so I think now there is a bit of change in the practice as recommended internationally. If you look at the WHO mentioned that antiretroviral therapy should be initiated for people living with HIV regardless of CD4 counts now. The other thing is we used to look at CD4 count to decide on the treatment. That's why I say don't wait for the CD4 count, because regardless of clinical stage and CD4 count, you start them on antiretroviral therapy as long as they are ready to start the treatment. And how fast, how soon? Various guidelines, WHO rapid initiation, even in fact a lot of emphasis on starting on the same day. That means patient come to you today, you see the patient, after discussion, patient ready, start the treatment. We do have some patients that actually are very eager to start treatment on the same day itself, and we did that for some of the patients. So ultimately, I think because patient is the one taking the treatment, I think we still have to, we will give them all the advice, and I think it's important to let them make the decision when they want to take the treatment. But I won't advise them to drag the wait for too long. Some they want to wait until they settle certain things. Some they are studying and they want to finish up their exam first. Some they are working and they want to go travel to a certain place. So we have to respect this thing and not to force them to start. I give you the treatment today, tomorrow you have to take the treatment, or tonight you have to take treatment. Not like that. Ultimately it's the patient that making the decision. Okay, but one thing is not necessarily waiting for 2 weeks of pill training anymore, and you can start the treatment as long as patient is ready and patient has no other complications from HIV or opportunistic infection. However, there are certain conditions that you may want to delay the treatment. Okay, remember that. If you can't remember anything else, remember 2 things. Any infection in the brain, be very careful. Okay, these are the conditions that you delay the treatment. One is TB meningitis. Okay, the WHO guideline says at least 4 weeks, delay at least 4 weeks after anti-TB treatment, but you should start within 8 weeks as if possible. But mind you, a lot of time patients, once they reach the stage whereby they develop TB meningitis, they're usually quite ill, malnourished, and these are the group of patients that usually develop side effects or complication with anti-TB. So be very cautious in starting when you continue anti-TB, and also at the same time when you decide to start antiretroviral therapy, because a lot of time they end up in trouble, okay, because of the side effects of the medication and also immune reconstitution. The other condition that we advise to, WHO advised to actually delay the treatment is actually cryptococcal meningitis. Okay, the reason why if you start on treatment too early, actually mortality is much higher. Okay, so the general advice is about 4 to 6 weeks after the antifungal treatment. Okay, so remember, these are the 2 conditions you generally delay the treatment, or there are certain conditions whereby the patient has still in the recovery process from the opportunistic infection that you are treating, you can actually delay it a bit, but most of the opportunistic infection within 2 weeks, you should be able to initiate your antiretroviral therapy. Okay, right. So after you evaluate the patient and all, like I mentioned earlier, you probably will come down with 3 categories of patient. One is asymptomatic incidental finding. These are a group of patients is like, the other one is symptomatic but have some constitutional symptoms with significant weight loss due to advanced antiretroviral disease. With advanced retroviral disease, these 2 first and second group are the one that probably you can persuade the patient to start treatment as soon as possible, which means may even the same day of you seeing the patient. The third group is a bit tricky because they can be quite ill. So you may have to treat the opportunistic infection first, and then after they sort of improving with opportunistic infection, then only you consider them on treatment. Okay, right. So antiretroviral therapy, I think yeah. So when we talk about antiretroviral therapy, always remember to remind the patient to comply to the treatment, because the first antiretroviral regime is always the best. And a lot of patients can take it like 20, 30 years, without any much of a problem. So always remind the patient this is the best treatment. If you fail this treatment, the subsequent treatment may not be as good as this one anymore, and it's more complicated, subsequently. All right. And these are the list of antiretroviral therapies that are so far available in Malaysia. I took out some, this was taken in 2017 guideline, but I took out some, if you realize Stavridine is not there anymore. Anyway, so it's a long list, not to worry about it. Ultimately, you as long as you know how to use tenofovir and efavirenz and maybe abacavir, it's probably good enough if you can't remember the others. Okay, and get to know about raltegravir and dolutegravir, because these are the a new regime that actually WHO had pushed everyone to start with. So this is a WHO recommendation. So if you look at antiretroviral therapy, the combination, this is taken from WHO 2021 guideline. It's always a combination of 2 NRTI plus 1 NRTI or efavirenz in our setting, or DTG is dolutegravir, integrase inhibitor. Okay, if you can't tolerate this group of regime, then the subsequent one will be 2 NRTI. So it's always 2 NRTI plus another agent. Okay, so it's always the combination is always formulated in that way. And this is WHO recommendation since 2019. I think dolutegravir has made a lot of breakthrough in terms of treatment, being a single tablet, single small tablet, very minimal side effects. That's why it's and it has a lot of other data. And if you are old enough, you probably remember efavirenz. Your usual dose is 600 mg. Now WHO also use advice of 400 mg instead of using 600 mg of efavirenz dose. Okay, so look at it away again. Efavirenz, this is WHO recommendation, is used as an alternative first line, and is the dose that they mentioned is actually 400 mg. Okay, this is my guideline. Mine is saya punya. Okay, because that's the only thing I have lah. That's why I say you have to remember how to use tenofovir, emtricitabine, and efavirenz. And maybe zerovudine, you might not even see need to use zerovudine. And why I put 400 so big and then 600, because 600 is getting less and less favor. And we are using more and more 400. The only problem with 400, we don't have a single tablet of 400 mg. So our formulation is still 200 mg per tablet. So it will be 2 tablets, 1 tablet extra if you take this regime of tenofovir, emtricitabine, which is in 1 tablet, plus efavirenz. Okay, so if you can use start your patient with 400 and not 600 anymore, as much as possible, because it's much better tolerated. Of course, when you have a alternative regime in your patient, after whatever you do still cannot tolerate, 600 efavirenz, then you may have to consider about using dolutegravir or raltegravir. This is currently my practice, but I think it will change in the future. You just have to wait for the guideline, but this is what is available at the moment. Okay, this is what is available in our setting. Of course, second line, we still have our old Calitra, which has been with us for many years and then still working good. Okay, right. So remember, tenofovir, emtricitabine, efavirenz, zirovudin, lamivudin, dolutegravir, raltegravir. So these are the common drugs that you will see. And I think it's easier if you get to know also a bit of side effects before we talk about the treatment. Yeah, so if we talk about abacavir, ABC is not the ABC song that you used to sing, but ABC is a short form for abacavir. Okay, abacavir is famous for its hypersensitivity reaction. Okay, and it has to do with something with a HLA-B5701 gene, and which is the test is not available, not freely available in Malaysia. So whenever we put the patient on, we are supposed to check for this gene, but then not commonly do because we don't have the test. AZT is zirovudin. Zirovudin is famous for its anemia. Okay, we used to believe that anemia usually happens within the first 6 months of treatment. Okay, but especially when the CD4 count is less than 200 and patient is anemic to start with and malnourished, it's more common in that group of patient. But then lately we have seen not many, not like 10, 20 cases per year, but then 1 or 2 cases per year of neutropenia or pancytopenia, which cannot be explained. And a lot of times zirovudin is still there. So I believe that zirovudin can also cause a pancytopenia or anemia, bone marrow suppression after many years of treatment. So keep an eye on it. Keep an eye if the patient had an old patient that already on zirovudin for many years and suddenly come with pancytopenia or anemia. And after you ruled out everything else, it could be the zirovudin that actually causing the problem. Okay, rarely you see lactic acidosis. Nowadays, I think we used to see a lot when we had stavudin with us. After 6 months of starting treatment of stavudin, you do see, but not so common with zirovudin. But as our patient live longer and all, I think they also experience lipoatrophy and lipodystrophy, which is sometimes very disfiguring for some of the patients. Okay. The other one that I didn't mention here, but then some patient may tell you is that they look a bit darker, they're hyperpigmented in certain places like the nails and the skin and all after they took zirovudin for quite a while. Okay, the next one is DTG, dolutegravir, the new regime. Raltegravir is a bit old. Dolutegravir is second generation of INSTI. The reason why I make it blur because not because I do it on purpose, because so far it has not so much of a side effects. So even though it's there mentioned somewhere and all, but then things like insomnia, hepatotoxicity, but then the significance of it actually the significance of the side effects actually not so much. So it's fairly well tolerated. Okay, the only concern is body weight gain or obesity after dolutegravir. Some patients did complain about it, but I think the recommendation that WHO mentioned was actually diet control and physical exercise. For most of the patients, even you put them on other treatment, after especially those had a significant weight loss, after 3 or 4 months, if the medication works, you'll be surprised with their weight because they can easily gain 10-20 kilos also after any other regime as well. If their baseline before starting treatment was actually very low, the weight. Okay, so remember DTG, dolutegravir and raltegravir is probably the future that you're going to see, in terms of new antiretroviral therapy that will be more and more common. Okay, the old efavirenz that we had, the problem with efavirenz is cause a lot of dizziness. A lot of patients complain it as a mabuk. After they take it with mabuk, usually within an hour or so after taking treatment, and especially when you take a lot of food with the efavirenz, you heavy meal and you took efavirenz, the side effects is much more. And if you take oily food as well, okay. And the other thing that we always concern is efavirenz may actually worsen some of the mental illness. If the patient already has some mental illness, it can actually worsen the condition. Okay. But with the availability of 400 mg, actually the CNS side effects is much tolerable after the 400 mg. You do have 1 or 2 patients that cannot tolerate 400 mg still, but the numbers are not much less compared to when we use 600 mg. Okay, so once you put the patient on 600 mg and then you put them on 400 mg, they will never go back to 600 mg because they feel so comfortable, you know. Okay, so remember, as much as you can, as much as possible, use 400 mg of efavirenz. Okay, and usually we advise them to take at night because of the mabuk and the dizziness. So they take it after 1 hour, the side effects kicks in, they go to sleep. The other thing they will complain to you, they feel very heaty after they take the medicine, you know, but it's a common thing and usually you don't have to do anything about it. Hepatotoxicity is something that we always, not always see, but then it do happens with efavirenz. You can always substitute with other agents if necessary. Tenofovir is another common NRTI that we are using, and kidney disease is the one that that we are worried. So do not initiate tenofovir-based regime if your creatinine clearance is less than 50 or 50. Okay, remember that, less than 50. Okay, if you want to initiate and you don't have, in certain conditions like patient has co-infection with hepatitis B, if you want to initiate, you might want to monitor the kidney function very closely, and that there are ways to actually use a tenofovir alternate days. You know, there are ways to, there are some recommendation to use that, but as much as possible, not to administer tenofovir if creatinine clearance less than 50. Okay. Right. So prior to your antiretroviral therapy, also look at comorbidities, like I mentioned earlier, renal impairment, Hep B co-infection, which you want to, as much as possible, include tenofovir as part of the regime. And then anemia, you want to avoid zero-budine, psychiatric problem, and also patient on anti-TB. Okay. And I think also look into, we used to talk about pill burden, and then pill size, pill burden, but pill size sometimes you might not be able to do much because that's how the company made it. But pill burden, we can do something about it. And then the side effects and whether food or fasting requirement and all is also equally important in certain medication. But of course, some medication with food, some without food, if the restriction is actually not very significant, try not to put too much of a restriction on this with food or fasting or without food. You know, some patients take 1 or 2 medicine is fine, but if they take 4 or 5 medicine, you know, some with food, some without food, I also get confused. You know, so easy way is everything you take at one time, then nobody is going to forget about it. Forget about the medicine, you know. Right. So I've just make this table, you know, just shorten. Just summarize it. If you have a renal impairment with creatinine clearance of less than 50, you might want to use regime that is containing abacavir. You know, but of course, when you use abacavir, lamivudine, efavirenz, pill burden is a problem. Abacavir 600, you might sometimes have to change the dose of lamivudine if the creatinine clearance is less than 30. Then there will be 1 tablet of lamivudine plus 2 tablets of abacavir, because 1 tablet is 300 mg. And then plus efavirenz of 400 will be, so you will equal, the patient will take about 5 tablets, you know. So pill burden is another issue. Then if hepatitis B, then try as much as possible to include tenofovir. If you can't take the tenofovir because of the renal impairment, you have to use the abacavir regime, then speak to gastroenterologist the need to add on a second agent for for hepatitis B treatment. Anemia, a lot of patients, when they are actually quite ill or advanced disease anemia, zero-budine based regime, we probably try to avoid. But if you want to use it, you have to, you might have to monitor it closely, and also you might have to cut down the zero-budine dose. Sometimes you can zero-budine. I think you can adjust the dose for anemia to, I think it's 600. You can cut it down to 500 mg, like 3 tablets in the morning and 2 tablets at night. But again, pill burden is a problem. Psychiatric problem, a lot of time, efavirenz is what we are worrying. But the problem is, you may not absolutely, you know, it's not absolutely contraindicated. You can't use efavirenz at all. If a patient has psychiatric problem, you can use, but monitor it closely. Okay, if at any point of time worsen a psychiatric issue, by all means take it off and switch it to alternative treatment. Social, if your patient is working shift work, like, they have to work night shift and all, speak to them about efavirenz. So far, if you're using 400 mg efavirenz, they are tolerating it quite well. If you have to use 600 mg, speak to them about the efavirenz and see whether they are willing to take the risk. But if not, then you may have to seek for alternative or try to get 400 mg for them. Police and army, I think you probably do have some, but efavirenz may affect their performance, especially police and army, because they, especially police, they work shift. Sometimes they work long days. So efavirenz again may affect their performance because of the CNS side effects. And also remember the urine. I still remember we always talk about urine toxicology screening test for cannabis. Sometimes it can be falsely positive when patients take efavirenz, and we used to give a lot of letters for the patients when they have when they are on efavirenz, because a lot of our patients actually during roadblocks, they are being blocked by the police and do the urine test. Okay, so remember this, because in police and army, they use randomly, intermittently, they do have a urine toxicology check. And for Muslim fasting months, as much as possible, try to give a regime that has a daily regime rather than a twice a day regime. Will be easier for the fasting month, so that they don't have to change the timing during the fasting month. So these are some of the ways that you can actually advise the patient and place your sort of like the way I talk as if we have a lot of choices, actually you only have tenofovir, emtricitabine, and efavirenz. Okay, and once a day is actually easy. It's a very easy regime, and especially when you have 400 mg, I think a lot of problems settled, and it can it's not one regime fit all, but NHF fit most of the patients. Okay. The other problem when you start antiretroviral therapy is always look at drug-drug interaction. Especially when you have a co-infection with anti-TB. Okay, rifampicin and anti-TB and nevirapine is definitely a no combination nowadays. If you have no other choice, you can use, but then not. Most of the time, we hardly use nevirapine anymore nowadays. So if you have to combine rifampicin, not to use it. Lopinavir or protease inhibitor and rifampicin, you reduce the dose up to about 70%, so you have to double the dose. Otherwise, of lopinavir, you have to double the dose, or you can use it. You can switch it rifampicin to rifabutin if it's available. Raltegravir, dolutegravir has a lot of interaction, so you may have to double the dose if you have to use use them with rifampicin. Raltegravir from 400 to 800 BD, and dolutegravir at 50 mg BD. And okay, yeah. So I think it's important. Otherwise, you can use rifabutin. Okay. And then efavirenz and rifampicin, 400 mg may be used as WHO recommendation, 400 mg. Okay. I used to think I just had I used to think that we have to switch it back to 600, but apparently WHO did recommend that 400 mg can be used when you combine with rifampicin. Okay, it's a very small study. If you look at the WHO's data that they use, actually, it's a very small study. Okay. Yeah, Hep C co-infection. It has, I don't think grazoprevir and gecaprevir is freely available, but if you are using these two regime with atasanavir, we may have to find alternative antiretroviral therapy. And then if you are using daclofasvir, then the dose of if you administered with atasanavir boosted, then you may have to reduce the dose to 30 mg. But if you're using together with efavirenz, you have to increase it to 90 mg. Okay, so this is hepatitis C co-infection. And that's why our HIV patients usually get 90, and I still remember we waited for a while to get the 90 mg preparation. The other thing that I think you probably won't see that much anymore nowadays, because our IV drug users are leading to HIV, I think it's much less compared to when I first joined ID. But remember, if you start them on treatment, if you are already on stable or methadone, and you start them on efavirenz, efavirenz can actually reduce the methadone dose up to more than 50%. So suddenly, after you start a few days later, the patient will start to have withdrawal. You have to remind the patient and also remind the doctors or pharmacists that prescribe the methadone for the patient to actually adjust the methadone dose, because that will actually potentially cause them to break through, and also they can default once they start to withdraw. They will default the medicine. Okay, so this is has to be taken care of. Especially remind the patient, both the patient, sometimes to the extent we actually give them a memo to give to the methadone clinic to actually increase the dose. Okay, lopinavir may reduce the concentration of methadone as well, and both drugs cause prolonged QT. So if your patient is on these drugs, be very careful generally we don't routinely do ECG, but in this group of patient on lopinavir and also methadone, you might want to actually check the ECG intermittently. Okay, mental health, quetiapine is one that actually has some interaction with our protease inhibitors. Okay, then like I mentioned, pimozide is the one is contraindicated with protease inhibitor, and also some of these medication like lithium, halo, and flufenazine can actually prolong the QT intervals when they actually combine with protease inhibitor. Okay, so do remember to intermittently check on them, especially looking at their ECGs and all, which is not a routine practice for most of the patients, but for this group of patients with a PI and also the psychiatric medication and all, you may have to do it regularly. Okay, the other one is hormonal therapy. So especially those with contraception. Okay, patient with contraception, you put them on efavirenz. They don't want to get pregnant, but 3 months later they will come to you and with a UBT positive. So remember to remind the patient, if they're on contraception, do take extra precaution, because with efavirenz you will reduce the dose of contraception, oral hormonal contraception. Okay, right. So so that they don't get pregnant, right? So, but if those are patients that are taking it for transgender and all, they're taking the hormones and all, actually efavirenz has not much of a problem when combined. It didn't cause much of an issue, so you can continue to use that. Right. Cardiovascular medication and all, there is a protease inhibitor actually increase the amlodipine dose by about 50%. So you may have to adjust the dose, and when you want to initiate the treatment, may not give so high dose, you want to cut down the dose. Metformin has something to do with the dolutegravir. Metformin concentration seems to increase, so you want to add on metformin to a patient on dolutegravir, do caution and so that adjust the dose accordingly. Simvastatin seems to be having some problem with PIs and protease inhibitor like simvastatin, causing risk of rhabdomyolysis. Atorvastatin with PIs, if you want to use it, you may have to restrict it to 10 mg. If you want to use atorvastatin with protease inhibitors, aptasanavir and darunavir, maybe restrict it to 20 mg if you are going to use it together with lopinavir. The problem is all these PIs also increase the cholesterol levels, and so a lot of them we ended up using more than 20 mg. Okay, but monitor closely because rhabdomyolysis is one of the problems. Okay, right. COVID-19 also has something to do with medication. Efavirenz do reduce the dose of dexamethasone. So you may need to increase the concentration. You may need to increase the dexa dose. And dolutegravir and raltegravir. Okay, if you're using calcium containing or magnesium containing, in fact, cation containing antacids, laxative, or multivitamins, there is a risk of chelation if you take it together. So you may have to get your medicine like 2 hours before or 6 hours after taking the medication containing a polyvalent cation. Okay, so avoid taking together. Remember that dolutegravir and raltegravir, and something to do with your calcium, not to take together, have to get 2 hours before or 6 hours after taking the medication. Okay, So after the first month of treatment is always important after you start HUD. Okay, patient may experience a lot of opportunistic infection still. They may have immune reconstitution. They may actually get worse and drug allergy as well. So mortality is highest during the first 3 months. So you might have to monitor them very closely during the first 3 months. Okay. Yeah, just this one is just to illustrate to you after the HUD treatment and all, actually the mortality, if you look at the red line, mortality is actually reducing after the antiretroviral therapy was introduced back in 2004, 2005, freely available. You see the mortality, HIV mortality actually reduced. Same illustration. And after 6 months of treatment, if your patient complies to your medication, you can actually suppress the virus to undetectable level. Okay, it's important to reach an undetectable level because you have a lot of data to say that U equals to U. It's not a song, but then it's undetectable means undetectable means untransmissible. And with this undetectable and untransmissible, we actually convert HIV to a chronic disease. And we have a lot of data to support this undetectable to untransmissible. If you're interested, you can actually read about it. Yeah. So in summary, when you have a HIV positive patient, confirm the status. Important, confirm the HIV status. Okay, especially those asymptomatic. Assess the clinical condition and decide whether at which stage of the patient that the patient is in. And then you counsel them about antiretroviral therapy. Make sure they accept the disease before you move on. Okay, initiate HUD as soon as possible, except when the patient has CNS complication like TB meningitis and cryptococcus meningitis. Always watch for drug-drug interaction. Most of the patient will be suitable with 10 mg equivalents and 10 mg and equivalents 400. Most of them will be tolerate the medicine well. The other difficult part is linkage to care. Make sure they always stick to your clinic. But of course, if they are wish is to follow up in other clinics and they wish to work elsewhere, feel free to arrange for them because nowadays antiretroviral therapy is not actually difficult to get. Many clinics, many our family medicine specialists are actually seeing prescribing antiretroviral therapy. Okay, and remember HIV with the antiretroviral therapy with compliance to medication is becoming a chronic disease, and you have undetectable viral load means untransmissible of HIV disease. That's the last slide. Thank you.
Thank you, Dr. Cheng, for a very comprehensive lecture. So let's get to some Q&A. Okay, I have here, when you say confirm the diagnosis, what do you mean by that? By HIV viral load? And how do we start treatment in the same day in a willing patient if we only have rapid diagnostic tests for HIV in case of a worried false positive results?
Right.
Yeah, this is about same day ART.
Right.
Yeah.
Yeah. So when I think if you look at KKM, I think KKM recently come up with a confirmation of HIV test. Go through that this thing or follow WHO. You look at the WHO chapter. There is a way to actually determine to ensure the confirmation. A lot of time you don't need the viral load to tell to decide on the treatment. I mean to decide on the confirmation of the test. Okay. A lot of time patient will present to you with an ELISA test and subsequently a particular agglutination test. And usually they will use fourth generation rich antigen antibody test, you know. So with that test and with a lot of time they also have some screening tests. I think with that test is probably good enough, especially when they have risk factors, you know. More confirming if they already had opportunistic features or opportunistic infection. All right. So not necessarily you have to wait for the viral load. Okay.
Yeah, I agree with Dr. Cheng. You know, I mean, if the patient is not convinced that the patient has HIV, you know, you're worried about a false positive test, we should not be starting ART for that patient. You know, you have to confirm the diagnosis first.
Yeah, so so the one that we said about starting on the same day is you're already very sure that the test results are confirmed and patient also convinced they already had the disease. but not necessarily wait for the viral load, because viral load can take months, sometimes 1 to 2 months to get back the result. Okay, depending on when and where you send it to.
Okay, we have another question here regarding Kyrexa and viral load. If a patient has CKD, eGFR of less than 50, anemia, HB of 8, viral load more than 100,000, would you consider Combivir to reduce viral load first, then change to Kyrexa?
It's too complicated if you do that, because when the CKD, you also have anemia at the same time. I probably won't do that. I will just start straight away with abacavir plus lamivudine and monitor the viral load. As long as you can comply, as long as you ensure the patient compliance, I think most of the time it works quite well.
Yeah, I think it's because earlier data saying that if your viral is more than 100,000, then it's Kyrexa is not as good in terms of viral suppression. But actually, when they look at longer data, it's the same. Right. In terms of viral load suppression. So yeah, we will start with Kyrexa. We won't start Combivir and then change to Kyrexa. Like as you say, it's quite complicated. Okay, next, what should we do to the ART when the patient presents with acute kidney injury or abnormal liver function test? Do we withhold the entire regime or serve one or two drugs which do not worsen the renal or liver function? Meaning, if you have AKI or abnormal liver function test, I assume with our first line therapy of 10-way EM, efavirenz, what would you do?
Right. So if the patient is not too complicated, sometimes you can have an acute kidney injury, but then a patient is not too complicated. They can still eat, Then I probably will just switch the regime instead of stop the regime, because I need the medicine. But in certain there goes with the hepatitis as well. If you think that efavirenz is the one that causing the problem, you can just withhold the efavirenz and continue, because efavirenz has a very long half-life. You can actually stop the efavirenz for 2 weeks and you still get the same effect. So you can actually stop the efavirenz, continue your NNRTI for a while and monitor the liver function. Otherwise, you can switch it to alternative treatment. Okay, that's for hepatitis. But if you have a renal impairment, a lot of time I will just stop the tenofovir emtricitabine and replace it with Kyrexa or abacavir lamivudine while monitor the renal function. Instead, I try as much as possible not to stop the regime. That's the principle lah. Because once you start, you stop, or you start, you stop, you actually ask for resistance. Number two is that stopping the regime may actually worsen the condition of the patient, which is already immunocompromised. So I try as much as possible. But in certain situations where patient is very ill, coming with septic shock or opportunistic infection with a lot of multi-organ failure, sometimes it's easier just to stop the whole regime and restart later once the patient got better. So it depends on situation, but most of the time I will try to switch to alternative instead of stop the regime.
Okay, there's a question on is there a way for Muslim patient who is on a BD regime? I assume if it's a first line regime, that would be nevirapine. Is there any other way apart of changing into OD regime? Is the patient on BD?
Right. So
yeah, this is mainly for fasting, I think.
Correct. So thank you, Dr. Wong. So when a lot of time, especially when they first started the treatment and viral load is still in the process of recovering, we try to advise them not to fast, because the viral load, the medicine may not be still stable. But for those patients that is stable, actually you can actually space out their treatment. That means they can take the morning dose at sahur, the latest part of the sahur, and then they can take their evening dose on the first time, the first thing when they buka puasa. So it will be more than 12 hours apart. It will be more than 12 hours apart, but most of the time when we do that in a stable patient with viral load suppressed, it works very well, without them having rebound of viral load and all. It's acceptable to do that if they are on BD medicine, provided they are already stable. That means viral load suppressed. We try not to do that when the viral load is not suppressed. Okay.
Yeah, another option is, let's say if they are really stable on the BD regime, if they are keen, sometimes we do offer them, to change to efavirenz, which is once a day, if they are not too affected by the CNS side effect. So you can actually change to efavirenz.
Correct.
Okay, if a person living with HIV co-infected with hepatitis C, will you treat both at the same time? This is again a co-infection with hep C.
Yeah. So generally, we will try to suppress the HIV first. Then we talk about the hep C treatment, because I think the priority is to still treat the HIV so that things will not get so complicated. And I think the hep C treatment works better when the HIV is well treated, or HIV is well suppressed. Then less complication, less problem to take care of,
Yeah, there's actually no contraindication to start together. It's just that, there are a lot of pills to take. So sometimes patients may be too, they're just like overwhelmed with so many tablets to take. Compliance may be that issue. Yeah. So, okay. If a patient develops diarrhea upon starting 10-way EM, what should we do? Do we continue the treatment? Patient has no other symptoms suggestive of OI.
Yeah, so I guess if the patient, you can just advise the patient and reassure them that it's probably transient, and you can give them some symptomatic treatment, and I will just move on rather than switching the tablets. Because diarrhea can be other reasons instead of 10 less likely cause. It do cause GI symptoms to a certain extent, but are not so common.
Yeah, we're actually running out of time. Maybe I'll just take one last question. After starting hard, when should we repeat viral load? And also, at the same time, also, when do you repeat a CD4 count? Do you repeat CD4 count? And, how do you monitor the treatment response?
So generally, I will actually you can monitor the patient by clinical, especially those very low CD4 count. After, like I mentioned earlier, after 2-3 months you start treatment, they actually gain weight. This is a good sign they're actually responding to a treatment. You don't have to have a CD4 viral load to tell you in that kind of situation. But certain patients that they are actually fairly asymptomatic, I will repeat their viral load and CD4 6 months later after starting treatment. Okay, probably won't do it too early. Generally will do it 6 months later. Some center did advise to do after 4 months of treatment, but generally I make it standard every 6 months, 6 months later after the starting treatment.
Okay, I think we should stop here now because it's almost 4 o'clock. I would like to thank Dr. Cheng for a very comprehensive and interesting lecture. And if for those questions that we were not able to answer, I think we will answer in the chat box. Yeah. Over to you, Dr. Chan.
Thank you.
Okay, thank you, Dr. Cheng and Dr. Wong for the excellent webinar. Thank you everyone for joining with us. This channel will be there will be a YouTube channel, and please to join us again next Thursday on the topic of HIV co-infection. Thank you again, Dr. Wong and Dr. Cheng.
Thank you.
Okay,
thank you everyone.
Thank you. Bye.